So let's talk about the context effect. Now, everybody that passes from being a person to being a treated patient has to pass through the therapeutic envelope. Now, that therapeutic envelope is the environment, which contains a lot of things. There's a lot of factors, and particularly this sort of patient-therapist interaction. This is very important. The confidence that they have in the person that's treating them, for example. All of these things can influence the outcome that they get. So let's look at how these contextual effects can work. And this has been studied quite a lot in placebo pills. There's certainly a lot more than it's been studied in placebo surgery. So let's look at studies using placebo pills. There's been studies showing that the color of the pill will make a difference depending on if it's blue or if it's red. It'll make people feel differently. The size of the pill, so larger pills have a stronger effect than smaller pills. The cost of the pills. Now, these are great experiments. I mean, this experiment, they got people in both groups in the trial to take a certain pill. And in one group, they had them sort of accidentally on purpose overhear a conversation about what the pill cost. And in one group, the doctors were talking to each other saying, isn't it amazing how cheap this pill is? You know, it really costs only a few cents. It's fantastic how cheap it is. And in the other group, they said, it's a scandal how much this costs. You know, this is one of the most expensive drug. You know, it cost us a fortune to get these pills. And so one group of patients thought their pill was expensive. The other group of patients thought it was cheap. And of course, the patients who thought their pill was expensive improved at a greater rate. The number of pills, so 2 pills has more effect than 1. And then you have these sort of active placebos. So this is a pill that has no effect. It's a placebo pill. But if you give people a placebo pill that does something, so in other words, it might make their tongue tingle, but have no effect on their body otherwise, they will have a stronger effect because they think the patient thinks that they got the real one. Now, if you go from an active placebo to a really more active placebo, you go from a pill to something like an injection, it has an even stronger contextual effect, or what some people call placebo effect. So if injections are better than pills, what's better than that? And so I think if you were to build the ideal placebo, you would have something that is painful, something that people can feel, that involves a procedure, not just taking a pill or an injection, but it involves a more elaborate procedure, preferably devices that are being put inside the body. And the whole thing should be delivered by a confident, enthusiastic, authoritative, important, and qualified provider. So someone, you know, like a surgeon, someone wearing a white coat. Surgeons are always very confident and authoritative. And surround the whole thing by symbols of science. And I think if you wanted to build the procedure that had the best placebo effect, it would probably be surgery. And that's why that title was chosen for my book. So these are what I've called contextual effects and what a lot of people call placebo effects. But what else is there? So the first thing is to explain this improvement that is not due to the surgery. It's where people improve, but they would have improved anyway, or they improved because of contextual effects, they improved because of something else. This is a logical fallacy, and it's a logical fallacy called post hoc ergo propter hoc. Many of you may have heard of this, but this is Latin for it follows, therefore it is because of. And this is a very human thing. This is ingrained in humans. This is a heuristic or a shortcut that humans have inbuilt in their brains. And so, for example, when we were, 100,000 years ago, when we were wandering the jungle and we ate some berries and then we felt sick afterwards, we would attribute that sickness to those berries, and then we would never eat those berries again. So you can see that this is like before we had scientific experimentation, this was probably a good way of sorting out things. And it's done us very well as human beings. but it's a fallacy. Um, and, and so why do people improve after surgery? We've talked about contextual effects. We've covered that, but there's three other things that we need to talk about that explain why people get better. One is natural history. What would have happened to the person anyway? Regression to the mean, which is a statistical phenomenon, and concomitant treatment, which is other treatments that the patient may be receiving at the same time. So let's cover these, and we'll go to natural history first. This is just a slide out of another placebo trial, this time in another type of shoulder surgery. I hadn't covered this one yet, but just showing how much people improve even when they have sham surgery. And this was often gets dawns upon many surgeons. They realize that this happens often late in the game. And there's a famous story that Cochrane, who is after whom the Cochrane collaboration is named, a very famous physician from the UK, who's one of the first proponents of evidence-based medicine and challenging current thinking. And he was around World War II and after World War II in the 50s and 60s. And he published a famous book where he talked about one of these sort of dawning moments. So he was like a young lad when he was captured as a prisoner of war in World War II. And as a medic at the time, he was put in charge of the health of 20,000 captured soldiers. Now, he had no access to medicine. He had no access to actual doctors. And he was captured by the Germans, and he complained to his German captors at the time, and he said, "There's 20,000 men here. They're very sick. They had typhoid. They had dysentery. They had open wounds which were infected. These were very sick, injured people, malnourished, and there was 20,000 of them. He thought that basically half of them were going to die." Without medical intervention. So he asked for doctors. And interestingly, the response he got from his German captors was the German phrase, Ärzte sind überflüssig, which means doctors are superfluous. So I think whoever said that at the time was a little bit prescient, because what happened was, after 6 months, Cochrane noted the 20,000 soldiers that he was looking after, out of those 20,000, only 4 of them had died. He was absolutely amazed. Now, interestingly, 3 out of the 4 that died were shot trying to escape. So almost nobody died of the terrible conditions that they had, and these wounds and dysentery and things, and they just got better without any medical treatment. He came back to England and he started thinking about things and challenging current practice. And one current practice at the time was, after a heart attack, people were kept in bed for a week. It was felt very important that if you had a heart attack, you had to come in hospital and stay there for a week and not move. Otherwise, you would stress your heart and you would die. And he said, "Well, what evidence do we have for that?" And they said, "Well, years of training, years of observation. We know that when we do this, a lot of people don't die." Now, of course, a lot of people don't die after a heart attack anyway, particularly if they've already survived the heart attack. And so he did a study where he compared people just lying around not doing anything for a week to getting them home and getting them active. And of course, the people who were more active did better. So he really started to put a spanner in the works and challenge medical thinking. So I think that's just a good example to put in there about natural history. What would happen to the people anyway? And in this shoulder study on the right, we know that the kind of conditions that these people had get better anyway. They don't need surgery. So what happens is we rush in, we operate, we see them get better, and we attribute that improvement to our surgery. Next thing is regression to the mean. This is a little bit harder to explain, but I can probably draw it. If we take a condition that fluctuates, and so here is the severity of pain, and over here we have the passage of time, And if we look at people, say, you look at an individual person who has arthritis in the knee. Now they may have periods where it's really not too bad, for quite a long time. Then they might have a terrible exacerbation, and then it might settle a little bit. Then it might come back a bit. Then it might get better, and then it might be good for a while. Then it might be bad for a while, really bad. But then it'll come good again. It'll be steady, and then it'll get better, and so on. It goes up and down. Now, if you take people at these points and do something to them, they will regress to the mean. This is the average pain. So this is what stock pickers do with stock prices. They look at the moving average. They look at the mean. And they know that it's going to always move back towards that moving average or that mean. So even when it's down here and people think, oh, my arthritis is cured, it isn't cured. It's going to be bad again afterwards. But if we take people at these points here and we do something to them, so for example, we do an operation on them, what's going to happen to them afterwards? They're going to get better after every time. Now, they may get worse again later, but that just means they need another operation. And then they can get better again. And I've had this argument with people that knee arthroscopy is ineffective. It's very well known that it's ineffective. And I've had this argument with people, and one famous argument I had with an old surgeon who was a big believer in knee arthroscopy. I said to him, we were talking about another condition actually in the shoulder, and he was a shoulder surgeon. And I was arguing with him about this other condition. And I said, I think it's a bit like knee arthroscopy where it doesn't work. And he got his back up and he said, oh, don't you start on knee arthroscopy. He said, knee arthroscopy is a great procedure. I've got an arthritic knee. He said, I've had 6 arthroscopies and it's worked every time. And to me, what's happened is he's had 6 arthroscopies at these points, so he's felt better afterwards. But then, of course, it's come back again. He's had another arthroscopy. It's felt better. It's come back again. He's had another arthroscopy. And he's still got arthritis in the knee, and he's still complaining. So it's really done nothing to him. But he believes that it's worked every time.